Many thanks for inviting me. I wouldn't want to miss this for the world. I am here to discuss new therapies for breast cancer. I will focus my presentation on a number of new agents that we use for treating breast cancer. We will look at the impact on safety. As you well know, a growing number of agents are available for addressing tumors, particularly breast cancer. This movement is a good thing, and the trend has been fast-tracked in recent years in terms of targeted therapies. Using Stéphane Houdar's example for prostate cancer, we have the exact same thing for breast cancer. So this gentleman tested use, and Sir George Beeston showed that following a bilateral ovariectomy, well, hormone deprivation could lead to a tumor response in terms of transitional metastatic disease as well. This was a transitional effect, but that was the very first indication for hormone therapy. And the cure rate of breast cancer, there's a lot of discussion about that in terms of screening and mammographies. But what's really increasing the cure rate is adjunct hormone therapy based on tamoxifen. And clearly, this is playing a major role in therapeutic success. Now, in terms of breast cancer, it is true that they are not classified depending on the type. Let me try and keep it short. The vast majority of breast cancers are hormone sensitive. In other words, they have hormone receptors. They're called luminal breast cancers. And then you have the quiet, little proliferative luminal breast cancers, HER2 negative cancers, for example. And these, usually, even when absent, even when advanced, are not going to progress very quickly, and they respond well to hormone therapy. And then you have intermediary forms, luminal B forms, which are hormone sensitive, but they proliferate much more, and the prognosis is often more circumspect. And this causes a lot of problems in terms of making decisions in terms of adjunct therapies. What should we do for prevention? Now, HER2 plus accounts for 15% of all breast cancers, and this is what I'm going to discuss now. There are changes in terms of managing these problems. Trastuzumab, Herceptin, is the initial targeted therapy for breast cancer. Let me call this our ball and chain. And then you have the triple-negative breast cancers, and we always have this discussion with patients who feel that they are triple-negative. It feels like triple jeopardy, and my female patients keep telling me, we need to come up with a new name. Triple negative sounds so negative, but it is a default it's a default expression. So, and by definition, the only treatment is a chemo, conventional chemo, which still prevails in terms of managing these patients. Now, there are two new drugs that are now part of our arsenal. First of all, estrogen receptor positive breast tumors, so ER plus tumors. When traditional hormone therapy doesn't work anymore, the idea is to try other transduction pathways. Yes, estrogen receptors, if we block them, we'll be able to stop cell proliferation. But even if we block the ER pathways, there are other signal pathways that may be activated, particularly the AKT-mTOR pathway, which can be activated and allow for cell proliferation. So one way of blocking that is to use other molecules that are going to block this pathway, particularly mTOR, mammalian target of rapamycin, which comes all the way from Easter Island. That was an interesting target for blocking cell proliferation. We first used a drug, which is now being used every day, everolimus, which was already widely used by in renal cancer treatment. And so Afinitor. Everolimus was used to render breast tumors sensitive again to hormone therapy. So metastatic cancer patients who had already been exposed to a prior hormone therapy following menopause received the standard of care. So this is what we call aromatase inhibitors, either letrozole or anastrozole. And we compared another hormone therapy, exemestane, alone with a placebo or with everolimus. And this is what we showed in spectacular fashion in terms of PFS. There was a significant gain in terms of bringing the disease under control. We went from 4 to 11 months of PFS with this type of therapy. And that really justified providing the marketing approval. The product was already available to treat other things, but it received a marketing approval for treating metastatic breast cancer. Now, this will doubt our enthusiasm, but do we consider that this modification in PFS justifies using this drug in terms of cost and in terms of side effects? That's debatable because, by and large, overall survival remains unchanged. There is a trend, but it is not significant. So there's an ongoing discussion for metastatic breast cancer. Yes, there may be several lines of treatment after the first failure, but is this diluted? The possibility of catching up at the end of the day, can there be a benefit for the patient? But this does not lead to a benefit in terms of OS, and yet that is the criterion that we continue to use for deciding that, yes, this product benefits the patients. Now, the problem with this drug, yes, it works, but how do we manage side effects? When dealing with breast cancer, yes, we are used to dealing with the side effects of chemo, side effects of various antibodies, but these things are new to us, particularly side effects that include stomatitis, in other words, mucositis to varying degrees of intensity, but also rash, fatigue, diarrhea, and also anorexia. And the loss of weight is sometimes significant. And the mTOR pathway, again, is involved in regulating glycemia, the glycemic metabolism, and sometimes this leads to hyperglycemia as well as a diabetic decompensation. It happens with this type of treatment. So let me give you an example of stomatitis. You need to warn your patients that this can happen. Stomatitis, mucositis, very painful at times, very embarrassing, very hard in terms of eating, particularly when the lady is already anorexic. And look at the oral lesions caused by this type of treatment, everolimus. And this shows up very quickly. Now, the curve. This happens during the very first month of administering everolimus. So management of side effects with this type of drug needs to be done in the first few weeks, because it is then that we find the most side effects. Now, a lot of work has gone into how we can manage stomatitis. Now, gargling, yes, that's simple. Using saline, not necessarily using bicarbonates, but as soon as the symptoms appear, what is most effective, once you have dealt with a viral or fungal overinfection, you need corticosteroids. That's what works the best against mucositis, whether using gargling solutions or topical applications. And here again, if the problem becomes too much to handle, you need to discontinue treatment. You need to wait for the mouth to heal, and you need to resume treatment after that. Now, things have been well codified, and you start again at reduced doses. And this whole conversation on whether or not we should start with reduced doses right away, but it hasn't been demonstrated. This is still being debated. How do we optimally manage the dose? And if the symptoms are too bad, then we discontinue the treatment for good. But this is something that we need to manage initially when managing patients. Another thing, interstitial pneumopathy. Thank God, most of the time, these pneumopathies are asymptomatic, outside of any infection. So the symptoms appear without infection being present. It happens quite early on, but sometimes there's a late onset. It doesn't happen that quickly. So in the first 2 months, as you can see, contrary to mucositis, once you've cleared that first milestone of mucositis, this is the pulmonary picture that you get in the vast majority of cases. It's completely asymptomatic, but if the symptoms appear and say there's a respiratory impairment, then you have to discontinue the treatment entirely. If the symptoms are low or weak or have simply been diagnosed on the X-ray but has no major impairment, then once you have an improvement, we can reintroduce the treatment. But surely this is quite worrisome and it's harder to manage. Now the stomatitis, that's painful, but there's no threat. There's no loss of life. It's easier to manage. So we're always much more circumspect when it comes to reintroducing a treatment when you've got neuropathy. And thank God it's rare, but sometimes there are acute complications which require high-dose corticosteroid therapy in order to improve the patient's condition. So you can clear that milestone. Rash is a possibility because of the treatment, and how do you manage that? Well, there's a variety of different management options. Now, this is a series of patients from different institutions. And if we take a look at this series of treated patients, over 100 patients have been treated, we find something that has already been described in literature. Toxicity of the drug leads to discontinuation of the treatment in 20% of the cases, which is significant. And so we may feel that this will be tolerated better, but this is a targeted therapy. But just because it's a targeted therapy doesn't mean that the treatment is easy to manage and better tolerated by all patients. And you find the exact same side effects: fatigue, stomatitis, rash, weight loss, diarrhea, anorexia, and these are the traditional adverse events you find, and this leads to discontinuation of treatment. Another therapeutic class now that we're learning to manage. These drugs were approved in the U.S. Marketing approval still pending in France. There's a whole class of drugs who are CDK cyclin-dependent kinase inhibitors. So you have an impact on this cell cycle already. So these cyclins are involved in various key steps in the cell cycle when switching from G1 to the S phase. This is a point of no return in terms of triggering the mitotic process. Now, by blocking the molecules using targeted therapies, those are treatments by mouth. So we block cell proliferation. And to some extent, in some areas, yes, this may look like targeted therapy, but this looks very much like anti-mitotic agents. So good old-fashioned chemotherapy. So things aren't that different, even though, yes, the safety profile is slightly different. So there have been a number of studies which have been carried out to randomize the phase 2 studies, but I'd like to talk to you about the most recent one. It was presented by Nicholas Turner at ASCO. It was published right on the heels of ASCO in the New England Journal of Medicine this year. So it uses a CDK, a cyclin-dependent kinase. It's called palbociclib. So the trial was called Paloma 3, and it compared the patients who had already progressed following a first-line hormone therapy, usually using an aromatase inhibitor, during either with an adjunct treatment or through a first-line treatment. In case of metastatic cancer, there's another therapy, fulvestrant. It's an anti-estrogen. So either used alone with a placebo or, again, with fulvestrant. So administered in the form of pills for 3 weeks associated with fulvestrant. Now, fulvestrant is injected IM. Also, what we find in terms of PFS is that there is a significant and impressive impact We're going from 4 to over 9 months of median PFS. So how much enthusiasm? This confirmed the randomized trial that showed the exact same thing. And here again, American authorities decided that this was enough to authorize prescribing and marketing this drug for this type of disease. But we're more circumspect because in terms of overall survival, the data isn't available yet. And so we don't have that information. And the randomized phase 2 trial that was used did not show any difference in terms of overall survival. So we're still waiting for the final results. Many trials looking at using this drug as a first-line treatment for metastatic cancers. Well, they're looking at that. Now, in terms of the safety profile, what we find is this. Using chemotherapy, the hematologic toxicity, we find also a neutropenia situation. What's really interesting is that even if we find an increase versus hormone therapy alone, the neutropenia rate goes from 3% to 80% with grade 3 cancers. So severe neutropenia, but the complication index is very, very low when you think about it. So there's a drop in white blood cells, in neutrophils, but there's a limited increase in infectious risks in this context. So hematological tolerance, safety is what we need to really pay attention to with this type of treatment. Very recently, at the European Congress, there was an analysis on quality of life. What you have on the screen is the impact on quality of life of the patient during the treatment. So palbociclib versus no palbociclib, that is fulvestrant plus placebo, we find there's a general increase in quality of life unless there are major adverse events connected with the treatment itself. So by and large, it's a positive balance, particularly in terms of pain. The treatment is a specific one that is often the best treatment in terms of pain management, particularly for bone mets. And here again, the time to deterioration of the pain score has been improved using palbociclib compared with the control arm with just one hormone therapy course. Now, if we look at HER2 plus breast cancers, it is another area where we have targeted therapies. I know there's a lot of information on this slide. I did it on purpose, just to show you how many different potential targets we've got. And this captures our imagination. A lot of attempts are being made to target some of these agents. Only some attempts have been successful. Let me talk to you about two recent possibilities, pertuzumab and TDM1. Now, the traditional treatment for HER2 plus forms, this medication has been available for many years. Now it's used for metastatic as well, metastatic cancers, but also as an adjunct. So it's we're about to switch to biosimilars to a broader extent. And as you can see, there's a lot at stake in terms of using this medication. Now, something has gotten better. We already have trastuzumab, which is going to block the oncogene with the extracellular domain of that receptor. We never really clearly identified the ligand in any way. So the extracellular domain of HER2 and the intracellular domain of tyrosine kinase. So this has been proven to be effective, but there's another antibody called pertuzumab. So pertuzumab is rather close to trastuzumab, but it's going to bind to another extracellular site. So no congestion, basically. It happens at a different place. And the site that pertuzumab binds to seems to be particularly blocked. It seems to particularly block the relationship with HER2's natural partner, its colleague HER3. So it's a family of human receptors for tyrosine kinase, so HER3. And dimerization between HER2 and HER3 is particularly involved in transduction of the signal. And so pertuzumab blocks a pathway, which means we can better block the dimerization process. So in practical terms, what has been shown? The use of this second antibody, trastuzumab plus chemo as a first-line treatment, this has been tested in a very broad international trial called Cleopatra. I love women's names for trials. I love empresses, goddesses. Sounds wonderful. All of these trials should go by women's names, in my opinion. How about opera heroines in particular? So the Cleopatra trial tested 400 patients per arm, so for metastatic cancer. So chemotherapy, docetaxel plus 1 or 2 antibodies. And just to keep things short, let's look at PFS. Very significant here, but as I was saying earlier for the other agents, here the discussion ends. Here we have a benefit in terms of OS, in terms of overall survival. It is clear, almost 16 months difference in terms of OS, particularly for people managing this type of disease. This means that now we have patients who have metastatic disease, HER plus, HER positive metastatic disease, and the overall survival is close to 5 years. It's huge. So we were already used to that, but that was only for a minority of patients. We had patients who lived more than 10 years using Herceptin, trastuzumab, and here we're expecting even larger contingents, larger hordes of female patients who will survive much longer with this type of treatment. So we keep telling ourselves, will we one day manage to heal metastatic breast cancer? In any case, long remission is now more and more possible. And sometimes you even wonder whether or not it makes sense to discontinue the treatment. We don't, of course, because thank God we can still afford it. And as long as it works and it's well tolerated, might as well continue the treatment. But it's one of the questions that we wonder for some patients. Why not discontinue the treatment? They're doing so well. So the safety profile for this drug, pertuzumab versus trastuzumab, by and large, pertuzumab is well tolerated. The side effects, cardiac side effects, are in the same league as trastuzumab. Now, the question that's coming out today, considering the tolerance profile, the safety profile is so good, using which taxane do we combine it in order to make this better tolerated by the patient? So either we use docetaxel or we use paclitaxel. That is, Taxol on a weekly basis, and this means that in some cases we can improve the safety profile, reduce neutropenia, because you have less neutropenia with weekly paclitaxel. It's better in terms of hematological safety. There may be an increase in peripheral neuropathies, but it's not the antibody itself that causes problems. And also in terms of marketing approvals, now it's now being approved for a first-line metastatic treatment, now also for neoadjuvant treatments. This was the result of the so-called Newsphere study. This study used HER2 plus cancers. So these are the different arms. No chemo here. They did it. 2 different antibodies, no chemo. And then, again, a chemo plus pertuzumab alone. Now, after intervention, you resume chemo, even for the arm that didn't have chemo initially, just the 2 antibodies. So later down the line, that is during the adjunct phase. And what's interesting here, and this is what the trial showed, that with the 2 antibodies, there is a significant increase in the response rate. Okay. This is the main slide, which shows that the 2 antibodies together clearly do better in terms of histological complete response compared with a single antibody. And also, what was really new is that 2 antibodies used alone can also lead to a complete response histologically in 17% of cases. So it's not a majority of cases, but in 17% of cases, it is possible to completely destroy the breast tumor using 2 antibodies without chemo. So We wish we had the biomarkers we need in order to select the population. But more systematically, we don't have it yet. I hope that one day we will, but at least we've shown that it's possible. So if we now focus on safety problems, here you have the LVEF, the left ventricular ejection fraction for both arms, for the different arms, even with 2 antibodies plus chemo. As you can see, sometimes there is a reduction in the LVEF, no more than 10 or 15%. So by and large, the safety profile from the cardiac point of view is rather similar to what we have with the single antibody, which gives us the green light for using the 2 antibodies. Same here for the safety profile. The side effects, as you can see, when we have the 2 antibodies, safety is excellent. 2 antibodies plus chemo, having 1 antibody versus 2 antibodies, most of the side effects at the end of the day, there is no major difference. So it is mostly, most of the side effects are caused by the chemo, not by the 2 antibodies. There may be a little bit more diarrhea with pertuzumab, but that was the only specific difference for this treatment. And as far as the rest is concerned, most of the side effects are caused by the chemo. I just want to emphasize that for this neoadjunct indication, there is marketing approval, 2 antibodies plus chemo, but it's not paid for by your health insurance. It's not paid for by Social Security. But it is indicated, but it's not considered as being validated. It's not validated for reimbursement, not validated for payment by Social Security. But for 2 years or 3 years, our American friends have used this combination, and it has made a huge difference in terms of the indications because it is available as a neoadjunct. This will increase the neoadjunct treatments indications, even for small tumors, so that the patients can actually benefit from these 2 antibodies. So this is a treatment offered from the outset, even before surgery. They get the benefit of the 2 antibodies, but only during the pre-op phase, not necessarily after, as an adjunct. Because for the adjunct treatment, we have no results, and we don't know that whether it makes a difference in terms of relapse-free survival, RFS. Now, the new generation of monoclonal antibodies. We're not going to sit on our laurels and just use the antibody trastuzumab alone. We're going to also include a cytotoxic agent, DM1. Our hematologist friends already did that for treating lymphoma, but this was the first development for solid tumor. It's now being rolled out to other pathologies. But for breast cancer, on top of trastuzumab, we include Mintensin. It's a cytotoxic agent that flunked the phase 1 exam and is now playing catch-up because DM1 was too toxic, clearly too toxic, led to major thrombopenia, and so we needed to bring it out of the cupboard, and now we use it at infinitesimal doses, very, very small quantities that we graft onto the antibody, and that is delivered directly into the cell. So the antibody binds to HER2, and the complex is internalized and will be broken down and will reload the chemotherapy inside the cell itself. So it's a targeted approach. It's going to have an impact on microtubule polymerization. So this is the antimitotic effect, a conventional antimitotic effect. So this drug was tested as a second-line treatment. So the female patients had already received the conventional treatment, that is chemo plus Herceptin, trastuzumab. And if that failed, we suggested another trial, and we compared TDM1, trastuzumab plus the cytotoxic agent, grafted to a linker, so alone, versus the catch-up, conventional catch-up treatment, that is oral chemo, capecitabine, plus lapatinib. And that's an anti-HER2, a targeted anti-HER2 agent. It's a TKI. So the 2 molecules together, and this is what the trial showed. Here again, the difference is clear. There's a benefit in terms of PFS, progression-free survival, 3 months difference. And mostly, here again, to wrap up this discussion, there's a clear benefit in terms of overall survival with this drug when we use TDM1 alone. And this was published in JCO, rather the New England Journal of Medicine, said the speaker, correcting himself. So the following year. So clearly this validates the use of the TDM1. So TDM1, that's Herceptin. So by and large, the safety profile is very, very good. A little bit of chemo is necessary. So again, it's not a silver bullet. And what we find is an increase in thrombopenia, some disruption of the liver, and a little bit more fatigue than if we use an antibody alone. So it is this cytotoxicity that we need to watch out for. We need to look at the hepatic situation and also the platelet count, which are things we need to keep an eye on. But in terms of cardiac safety, the rate of the drop in LVEF is very comparable to Herceptin alone. So relatively moderate for patients who are closely watched in terms of their LVEF, pardon me. So this now prevails as a second-line treatment. So first line, 2 antibodies, pertuzumab and trastuzumab, plus chemo, and the second line of treatment, now TDM1. And as a third line, lapatinib. We still have lapatinib. It still prevails. There's room for it later down the line. And this molecule is still subject to a number of side effects, particularly the main one, because again, these are continuous treatments, and the main complaint from patients is diarrhea. Diarrhea to varying degrees of severity, but almost 10% of grade 3 or 4 diarrhea using this drug. In the initial studies, where people are not really careful in terms of managing the treatment, in countries where things aren't as closely monitored, where there were other prevailing infectious diseases rather than cancer, there were deaths caused by toxicity in a number of studies, caused by infectious disease that came on top of that came on top of diarrhea, the diarrhea caused by lapatinib. So sometimes you've got rash caused by lapatinib, and generally you manage that pretty well. So no change in the treatment, and most of the time, because of the rash, usually you reduce the doses because of the GI side effects, and also cardiac safety is still pretty good. Florent, are you winking at me because I'm supposed to stop? I get the message. All right. I had, backup slides, if you'd like me to talk some more. There are other smaller targeted molecules that constitute an alternative to lapatinib, but we still wonder whether it'll reach marketing approval. It's still being investigated, but there's a very interesting trial. Neratinib is another molecule that also targets HER2, administered by mouth. If you administer it after the conventional treatment, when you add that, you get a benefit in terms of PFS, and the side effect is the hardest thing to manage, and that's diarrhea. Diarrhea is caused by this agent, and the lab working on it and developing the drug now demands that all investigators be specifically trained in managing diarrhea. They should be certified in diarrhea management before they can continue with the trial. A quick word about breast cancer. Here we have bevacizumab, very well known, already used for other types of cancer. But here we're discussing it and whether or not it has a place in terms of treating breast cancer, because in all of the trials we've done, whenever we add beva, it's an anti-angiogenic, and we add it to the chemo. If we combine all of the studies, clearly there's an increase in the response rate, and here again, an increase in PFS. Here again, as you can see, the curve calls it into question. There is no OS gain. There's no benefit in terms of OS. Conversely, our American friends are ahead of the curve. They're ahead of us. They were the first to achieve marketing approval and also the first to withdraw it. They withdrew this molecule for treating breast cancer because they decided that the cost-benefit ratio, and I'm also mean the financial cost, relative to the safety profile, means that continuing to use Beva as a first-line treatment for breast cancer doesn't make sense anymore. Now, the marketing approval in France continues in association with Taxane, paclitaxel, but there are lots of questions in terms of which population actually needs this treatment. For which population is it really beneficial? When we want a faster response rate, a higher response rate, it works. Relative to a combination therapies, the rate is very similar to the kind of gain you get with combination therapies. And in some European countries, the indication has been restricted for triple-negative metastatic breast cancers in particular. In other countries, they decided, okay, we're going to keep it, but the indication is rather circumscribed. And there are a number of side effects that must be managed: hypertension, perforation, hemorrhaging, and brain problems. Posterior encephalic leucopathy can happen. And it's unfortunate, but this is something you need to know about because you may have rather specific neurological syndromes appearing. And I will wrap up by discussing the questions we're asking ourselves. For many tumor-related pathologies, solid pathologies, you need to determine the place of immune checkpoint inhibitors. We have no real tangible results here. And the molecules, the agents that are the most studied are the so-called triple-negative tumors. Several studies are underway to try to test this type of drugs. Early trials in particular show some type of response, but we are far, far removed from marketing approval. So the studies are still underway. And again, we wonder about the safety profile, bearing in mind that the new generation of such drugs are much better tolerated than the patients, particularly the initial the first generation inhibitors are hard to manage. So thanks to the new generation, we will continue to evaluate the benefit for the patients, particularly for aggressive triple and negative tumors. Many thanks for your attention. So yes, such targeted therapies show better safety by and large, and also it is the natural history of HER2 plus tumors. In the past, those were severe diseases with a better prognosis, and now it's the opposite. We're looking at the most favorable forms of cancer, but just because it's a targeted therapy doesn't mean toxicity is less. There may be some treatments that are very, very difficult to manage in terms of side effects, and quality of life suffers. Everolimus studies showed that, well, there's no major impact on quality of life, but because the response rate increases, at the end of the day, quality of life is rather similar with this type of treatment. Thank you for your attention.
Un grand merci, Jean-Yves.
Thank you very much, Jean-Yves, for keeping up with the schedule, and Laurent just turned up. Do you have questions to Professor PIERGA? I have two questions. Try and save time so that Laurent doesn't turn up all sweaty. What do you mean by efficiency biomarkers? These are certainly the future for immunotherapies. Do you have tolerance biomarkers for these various treatments? No, not necessarily, not especially. It's true that when we take the everolimus, the therapies that are going to target the AKP3 kinase, we focus on these mutations, the mutations that are frequent in breast cancer and express a reaction to hormone therapy. But none of them seemed associated to a greater benefit from these treatments. But we weren't able to identify clearly populations with specific polymorphisms, which we could associate with a lesser level of tolerance for these treatments. But such researches are often carried out. We have a trial that's ongoing with the Gérard Milano team from Nice, dealing with a broad cohort, and paclitaxel and Avastin together are going to be studied here and see what it modifies, not in terms of efficiency, but in terms of tolerance. And you spoke of oral immunotherapy. Do we have new developments in monitoring the development of such therapies? Well, there's an official side to this. We have guidelines to abide by to put this into place, and I'm looking at my colleagues from the Curie Institute. So some initiatives were launched, consulting nurses and other members of staff dealing with the monitoring of these oral immunotherapies. We have to be able to know who we can turn to get information and manage the side effects. But this is the problem here. It's the acknowledgement of the nurse consultation. There's a first screening by the GP, but there's also recognizing and enhancing the value of new professions, and we have some new approaches to requalify these skills. But of course, this represents zero in terms of profits for the institution, and we are in a world where economic constraints and time constraints are getting greater and greater.